What a perfect lead-in to Dr. Cunningham's talk. Rebecca Cunningham is an Associate Professor of Emergency Medicine and Director of the Injury Control and Research Center at University of Michigan in Ann Arbor.
Great, and thank you for the introduction and for the invitation today. So it's late in the day and everyone probably needs a little coffee. I'm here to bring you a lot of pretty pictures for this afternoon, for this next half an hour or so, and keep you awake. Hopefully the technology will work pretty well here. Sometimes I have a little bit of trouble with it. Nope, that went nowhere.
It's a beautiful picture.
Down. You want me to use this one or this one? This one. Okay, perfect. First, a thank you to my collaborators. Many of these people were mentioned earlier today who have led some of the studies and or worked on the studies with me over the past couple of years. I'm going to talk a little bit about using technology, and I think Gail and Doug's setup here was perfect. So from Gail, you heard a lot about what SBIRT is and how we can help patients who are having substance use, both problems, misuse, and addiction in the emergency department. And we've spent a bunch of time thinking about how we can do that with people and how we can do that with emerging technology over the past decade or so. And the overview of this talk will be, I'd like to talk a little bit about how we can use computers both to do screening, and I'm not talking about EPIC here, although I think as EMRs come in and our screening technology gets better, eventually they will merge. We're just not there yet. To talk about using computers both in screening and then using computers both in intervention, and really in two ways that we can use computers for the intervention, both to help the person when there's a person there, and then to get at the idea of whether there can be a standalone computer piece as well in our futuristic ideal vision. I'm going to give examples and lots of pretty pictures from 3 studies, particularly to kind of highlight these examples from 3 different populations. The first is Project UConnect, which is suburban, so Ann Arbor-based underage drinkers 14 to 21 who have alcohol misuse as a cutoff. Healthier U, which is adult Flint, urban low SES population addressing drug misuse, also with comorbid HIV risk, addressing that as well. And Safer Teens, which was mentioned a little bit earlier, which was a intervention program focused on urban teens with alcohol use and also co-addressing their violence. So screening. How we can use computers and why using computers versus paper and pencil I think is relatively obvious. It wasn't that obvious a decade ago necessarily. But what you can do on the computer is really complex skip patterns that you can't do otherwise, which makes things very quick. So I'm going to show you lots of pictures here, and this has evolved. We started doing computerized surveys in the ED in the mid-90s, and so you can see how that's evolved over the last 15 years. So now everything is basically either iPad-based and or tablet-based, and it's touch screen. For low literacy rates, it can be read to them for our populations that have very low reading rates. You can, again, do skip patterns that you can't do very easily on paper and pencil. The technical term is ACASI, or Audio Computer Assisted Self-Interview. The advantages are, one, you can really get at a lot of sensitive information. We find, somebody asked earlier how people respond to the computer versus the person. There's been a number of pretty good studies that show, and I think we all know this from our own use as well, people are pretty responsive, especially younger kids. But certainly adults as well. The computer is impersonal. People will report all kinds of things to the computer that they may or may not report as well to a person. I actually think people are pretty honest in reporting to the therapists as well, over and over, from what Gail was saying and from what we've seen from our own work. I agree with that completely. But we also find that in the computer versions, people are very honest and are willing to kind of go through quickly and give the information that they needed. There's less social desirability. For surveys, so we have the 2 things that are advantageous about using computers for screening are one, again, it's quick. Here sometimes people have the headphones on, sometimes they have the headphones off in this picture on the left, and it's just an efficient way to move through and to capture information. The second part about it that is maybe less obvious is the data from the survey can be assimilated then into the intervention later on. So that can both make what could be a computerized intervention more efficient, or it can feed the information from the survey to a therapist who doesn't have that much time. and really narrow down and highlight for them what the information is that they self-reported. Because we have a wide range of people who we're giving our surveys to. Some people are low risk for alcohol, high risk for marijuana use. Some people are high risk for violence but using a lot of cocaine, let's say. So this can help filter all that information out in a very quick way. For the screening, again, this has evolved over the past couple of years. You can either use software-based screening packages like Sawtooth, which are a little bit tedious. There's increasingly Qualatrix or internet-based programs. I'm not going to spend a lot of time on that. Here's a sample of one of our typical screens that goes through on an iPad that we do very cheaply. We use this format for lots of kind of easy surveys in the ED right now, which we hand out to people and they click through. Screening for risky alcohol use among youth. Again, you can put the pretty pictures up. They can click through very quickly, confidentially. They can do this well in a sling a lot of the time. They can move through and do this privately. So that's a little bit of kind of the overview of the screening component, although really we want to move beyond screening, as somebody said before. We really want to move to the intervention part. So how can we use computers in brief interventions in the emergency department? And really there's two types. And I think I'm just getting a little dizzy here because this is so down, but that's okay. There's two ways I'm going to talk about this. So there's computer interventions which are computerized completely. So standalone, there's no person involved. We hand the participant or the patient a computer. They go through the entire intervention on their own, and there is nobody else involved. Now, this is dreamy if we can get it to work, because we all know that we're under-resourced and people cost more time than anything else. That being said, it's still a little bit of a conundrum of how much we can get that to work and how much we can't, and I will show you some of the data that we have on it. That being said, again, though, the needle is continuing to move, and I think as we learn more about what the black box is of SBIRT and what it is that works about it, the better we may be able to continue to move that into computerized formats in a way that may be accessible. Will it ever be? And the therapists in the room usually start throwing things at me at this point. It will never be as good, I think, I will suspect, as a real person for most of the time. However, if there is no real person standing in your emergency department, it might be good enough. It might be good enough for some portion of the people. It maybe isn't good enough for everybody, but if it's good enough for some of the people, then it's better than them getting nothing a lot of the time. The other way that our group has used computers and thought about computers over and over again is to really help the therapist-delivered interventions. And there's a number of ways you can do that. The therapists that often are put into situations to do screening and brief intervention in the emergency department are working at all kinds of crazy hours. May just be, I heard somebody say before, just out of their MSW, may or may not have tons of training. Even if they're very well trained and very experienced, our most seasoned therapists, when we toss them in, are initially quite surprised that they're doing interventions next to a curtain with a screaming baby who's getting poked, and they're a little distracted because they're trained to do therapy in therapy rooms that are quiet and very calm, and that's not where we live, and that's not where they're going to work, and that's not where they're going to have to pull this off. So the tools that we can give them on a computer to help them give the information and cue them along the way, give them information that they don't have time to ask from a baseline survey that they maybe don't have to give, will help with their time be efficient. Also, the other piece about the computer that assisted therapist interventions that I like, and I think maybe why we see some success in some of our therapist interventions that other people haven't always seen consistently over time, is it really helps nail down fidelity. So the best interventions in a research study don't necessarily translate to the hospital and practice settings because the therapist starts winging it. And they get tired and they skip sections and they skip to the end and they forget a whole component in the middle. But if they are forced to kind of move through computer screens, then they don't get to do that as much. Now, they can still skip here and there, but it helps them kind of stick a little bit better. Now, there's old-fashioned formats to do that just as easily, and my colleagues that have been around doing this longer than I will say, Rebecca, isn't that just a workbook, basically? Sure, it is. It's a workbook. So you can think of the computer as a workbook in some ways that helps guide them through, except for it's a tailored workbook that gives them information along the way and then can also record information as they're going along. So it's a little bit fancier. And this goes through a little bit of that. The computer tailors for the therapist. It saves time. It can record the data. So, and then you have this picture on, this is the therapist here who is using the computer, and there's screens that we develop then that are therapist facing that only they see, and then there's times where they turn around the computer and they share it as a workbook with their participant. And again, it helps ensure that they don't skip content sometimes as well. Again, our goal in some ways it would be nice if we could move to a standalone intervention. We may or may not be able to do that eventually. I think some component of it may be able to eventually be just standalone. But it's really important when I show you the pieces that we're doing, the computerized interventions we're talking about are not passive videos. They are not watched and received. It is not a TV program. They are interactive, and the participant has to be interacting the entire time. So an example from UConnect. UConnect, again, is underage drinkers, so 14 to 20. And I'll play you a clip, hopefully. Wait in a minute for this. I think I can start it up here. You'll hear some of the language in here, which is harm reduction. Again, we are funded by NIAAA for this study. Drinking under 21 is an illegal behavior, so we have to be careful when giving that message back and forth to youth. Let's see if I click this. And I was hoping I was going to be able to kind of stop it and move along. I may not be able to do that. The whole clip is about 4 minutes, and I may just let you run through it. Let's see. This is the. Oh, let's see. Can you start it from there? If you click on it, it should. Yeah. Well. You don't have the hard drive to fill it up, do you?
No, I don't have access to this.
So we may have no clips. That's unfortunate. All right, we'll keep going. We'll see. There may be one later. Okay, so again, 14 to 20-year-olds, they are screened in with an audit. So, and they're screened in by everyone is basically handed out a version of an iPad or a tablet. They're screened in, and the computer does the scoring for them, which gets around some of the problems that Gail was talking about before of whether it's how complicated it is and has to be self-scored right on the scene. The computer does that in the background. It codes whether they have they're younger 14 to 17 or they're older 18 to 20. It may not be on that slide. We'll keep going. So we screened about over 4,000 people, and we put them in 3 groups. We put them into computer intervention, computer-assisted therapist intervention, and basically a resource control. And just so you know, because when you see the actual computer intervention, it's easy to forget sometimes that we're not just kind of making up all these different pieces. These have the same components of brief intervention, the theoretical components of brief intervention in it that Gail was referring to before. It has agenda setting, it has goals. We present normative and personalized feedback. We go through reasons to avoid drinking or drugs, the benefits of that, personal strengths, other better things to do, in the same kind of theoretical framework that the MI therapist interventions do. Risky situations, tools. For this drinking and driving one, for this drinking intervention for underage drinkers, we go through a drinking and driving scenario also, and then a summary plan is given. So those theoretical components are all woven in. I will not show you all of those, but I'll show you the clip. You're right, I think it was later. So the therapist intervention, and this screen that was a screen that only the therapist would see. So this is the screen that a therapist would get, cueing them to remember to say, you've asked you a bunch of questions about your drinking earlier. Would it be okay if we talked a little bit about this? And then it gives them the information on the screen that they said that they drank 4 or more times in a week. They drank 10 or more drinks. They're binge drinking almost daily. And then they can prompt them to have a little bit more conversation. Now, a good therapist in a regular setting can certainly elicit all that information on their own. But we're also trying to get them to be able to deliver an intervention in 30 minutes. So if you're going to facilitate that, giving them that intervention in 30 minutes, we have to give them some tools. And then for the therapist that then gets distracted by the baby who's screaming next door, and because we stop and start the intervention as people need to go to x-ray or do whatever they need to do to not interrupt clinical care, we also give the therapist hints kind of along the way to help have them remember where they are and move along. The same piece here, this is a screen where the therapist would then now turn it around and face it to the participant and say, so they're going to go through and they'll talk a little bit about what are some of the tools that might work for you to drink less, and they can click some of them and they can talk about it a little bit. And then those check boxes, unlike what a workbook would do, although a workbook you could give to the participant in the end, the check boxes here then get recorded and then get fed into a summary sheet that gets given to the participant in the end that's tailored, that then says to them, remember, these were some ways that you thought you might be able to drink less that we talked about. Will they keep that? Maybe. Maybe they'll file it circularly. Hard to know. But at least we have that, and then they can have it to go over with. Again, these are some more typical screens that we have for using the computer as a workbook that they would go through with the therapist and kind of check through. Reasons that they might have problems with school or work, friends or family, legal problems, or losing control, injury, and health. And they can go through and have a conversation about that with the therapist, with the computer guiding the therapist through. So how acceptable was this? And that's completely standalone, so they don't need a therapist for that. Is it as great as a therapist? Probably not. But maybe is it better than nothing? Probably. It's not quite clear yet, but we're working. I'll show you some of the post-test data. 94% of them completed on their own. It should be mean, not median time. It's about 35 minutes, 30 minutes. So if within a 30-minute time period, you get somebody who gets an intervention without a therapist having been paid to do it, that they gave their own self-assessment for ahead of time, and the information is fed into the computer. At the end, they get emailed them a little booklet that has the tailored information that they put into it that was most relevant to them. Acceptability was pretty high for teens. I mean, older adolescents, for those of you who have kids between 14 and 20, there's not much they really like, so if they don't hate it, you're really kind of doing all right. So 90% report that they liked the program. More people liked the therapist, which our therapists like to hear, but enough liked the computer and found it acceptable in the 75, kind of 80% range that we're pleased that we hit it relatively on the mark. More importantly, what are we seeing so far? We don't have, the trial is ongoing, so I can't show you outcome data for this, but we do know from the post-test, which is complete, we have some good things. So the importance to cut down, readiness to stop, likely to cut down, those are all significant findings that we have here, both for the in the computer and then in some places for the therapist as well. And you can see that here. The computer is basically, the yellow line is moving in a good direction and is significantly different than the control. The same thing here with likelihood of cutting down in the next 30 days. And this is post-test data. So whether they're able to implement that over the 3-month follow-up and then the 12-month follow-up, you'll have to stay tuned. So that's been kind of an example of how it's possible to take an SBIRT type platform and move it into a computerized method and using technology. So now you're like, that's great, but that's teenagers and it's underage drinking, and will that ever work for drugs? So Healthier You is a study of adults in inner city Flint, in our trauma center there, and is looking at whether it moving a similar concept towards applying it to drug use. We also address HIV behaviors. We've screened 4,500 people, and we have them randomized right now into groups of about 250 each. The same type therapist screens start, where the therapist will review their different goals or move through them with the therapist, a computer-guided or assisted therapist program. And these are what the screens look like for that type of platform. In the computer intervention, the adult gets to pick a health counselor to walk them through a computer-based intervention. There we go, I can advance it. So when we first started this Healthier You one, we were a little bit skeptical. Could we get adults, pretty low income, low resource participants to sit through a 30-minute intervention on the computer? And we've been really overwhelmingly surprised. We've been very pleased. The literacy level is low, but the questions are read to them. The computer was set up in a format where everything could be taught to them, and they could move their way through it, and they were able to do that increasingly well. And increasingly, you know, as we move to this a more computerized, computer savvy population, even older adults in a low resource environments are increasingly computer savvy, and so this is a format that may work for them. We find, again, we finished both the therapist and the computer intervention in about 30 minutes with again, quite good rates of acceptability in the 70%, with many finding the intervention extremely helpful and very helpful. What are we finding in post-test? And this is just published. Dr. Bonner, our postdoc, just published this in JSAT with outcomes with just post-test outcomes. Again, this time we don't have 3-month outcomes yet. Finding good, suggestions that we may be on to at least a good track with intention to use drug in the time versus the therapist group with good effects, and their confidence that the program increased their confidence to reduce and quit drug use. In terms of repeated measures for other constructs, the computer also looks promising in several realms. And then interestingly also, in terms of, this is NIDA funded, we also looked at HIV risk behaviors and incorporated that into the program, into the feedback they got. and have suggestions that that it was at least positively received, and at least at post-test there's suggestion of changes. Whether those hold up or not at 3, 6, and 12 months, we'll have to see. I'm going to talk just for, I think I have 5 minutes left, about Safer Teens, which was our older computer program, and you'll see that very quickly when I put it up. So we started building this program in 2003 or 2004. Technology and computers were a long way away from where we were now for graphics. This is a program for an ED-based brief intervention, which was focused on alcohol use and violent behavior, specifically among the same teens in Flint, Michigan, so in an urban setting that this later program, the one I just showed you, focused on for their drug use, talking about together decreasing their alcohol use and decreasing their violent behaviors. And we really focused on that program on both just as heavily. They had to be 14 to 18. They had to have had some alcohol use in the past year and had to have some interaction with violence in the past year, very low-level screen-ins. We've screened over 3,000 people. We have over 200 in each arm. And I throw up this very messy slide specifically because it's very messy, just to get across the point that the programs are all tailored. And again, that's one of the things that you can do naturally in with the computer. A person does this all the time, makes choices about what's the most relevant or what's the most important thing for our participant to hear. On a computer, that needs to be programmed in. So we had kids that were low violence, meaning they had some interaction with fighting or violence in their life, but that wasn't their main problem. We had kids that were were low on alcohol use. They really had more problems with violence, but less problems with alcohol. And then we had kids that were really very involved with both. And the algorithm that we programmed in for them to get varied and was tailored based on those pieces. This is the therapist, again, the therapist screens, which looks similar to the screens that I showed you before for alcohol. And go through with the team what is important for them: money, staying healthy and fit, some reasons that they may want to be less involved in fighting and or alcohol use. Again, these are the therapist screens that they received information that was tailored from their baseline survey about what the kids' behaviors were in the past year, and that way they could talk to them immediately about the fact that they had pushed someone, they had beat someone up, they had kicked someone in the last year. We included in this one a dating violence component as well as a peer violence component, and we had positive effects with that. The feasibility and acceptability, again, were positive, where we found it took about a half an hour to administer and was very acceptable to teens. And again, the characteristics I throw up here, and these are similar to the adult drug use study as well, this sample is about half African American, more than half on public assistance. Most of these kids have failing grades. About 10% have dropped out of school. A lot of binge drinking. Marijuana is the drug of choice, overwhelmingly, and many had experiences already of their violence. So a fairly at-risk population. We found in this at 3 and 12-month outcomes that we were able to decrease severe aggression in the therapist component of that program. Again, computer-assisted therapists compared to the control group. And there's a slide of that. For dating victimization specifically, we found that the computer was able to decrease moderate dating violence at 3 months and at 6 months. And alcohol consequences, we found changes in the computer compared to the control at 6 months. We're in press now is a cost analysis, and Gail put up that kind of $2 to $3 standard that we've seen over the years for alcohol interventions. We find for Safer Teens, based on a very conservative analysis, it costs about $9 probably if it were to be rolled out to avert one violent event over the following 6 or 12 months. So that's a lot of information, mostly meant as an example of how we can think about taking what we know theoretically about screening and brief intervention and applying technology to it. And I believe that will be something that, as the technology continues to advance and as our understanding of screening and brief intervention continues to advance, eventually there will be a natural meld there that happens that will either be facilitated by technology and delivered by a therapist, or in some cases, perhaps in lower resource areas, delivered by a standalone computer intervention. I'm happy to take questions.
Questions for Rebecca?
You know, I have a question. I've already talked too much, but maybe you get this knowledge exchange going late afternoon postprandial. You know, so there's going to be this acceleration in technology, and at what point do we need to do trials on every new technologic innovation, and at what point can we begin to say, you know, this was safe, this people like this, you know, especially considering the I think what really is key about acute care settings is like unbelievable heterogeneity. So are you going to do it for every, you know, 14 to 18-year-old now who's a 30-year-old in 12 years? I mean, how do you think about that?
Yeah, I think we need more funding to figure that out. I think we can't do it for everything, and obviously you see there's a pattern to some of the studies that the group has done, but pieces of those separately, although look obvious in retrospect, aren't obvious at the time. So any brief intervention at all that involved violence, is novel 5 years ago. An application of computers to that is, as that technology comes forward, is still novel. As we fast forward that to Facebook or social media sites, I think it's a mistake to assume that because something worked in one setting with one technology, that when it's moved to something else, it will work. It will work in the same way at all. So I think we have to be careful. I think not studying the translation of some of these concepts to other pieces is a mistake, because then resources wind up getting put into widely rolling out things that don't work. But that being said, I think if we find something in this piece that works in this way, then do we need to study it necessarily for every particular drug or every particular age group? Maybe not, but then we probably need to figure out which components of it work and which components of it don't work, and pull out the ones that don't matter so much and focus in on those, because maybe in the 30 minutes that we delivered, the only thing that mattered was really 8 minutes of it, and that would be a heck of a lot easier and more cost efficient to deliver than the 30 minutes. So I think you're right. We have to be careful in which things we keep throwing money at to develop. On the other hand, the developing of the technology interventions in and of themselves is not cost, is not cheap. And as we look at rolling those out to remote therapies or to iPad apps, there's an initial want to take, okay, well, Save Your Team worked like this, so can't we just slap it on an app and throw it out there? Well, that will work. Well, will it? I don't know. I'm not sure it will at all, and I think it's a mistake to just say that it will that way. So I wish it was easier.
I have a very practical, not very scientific question, but it relates to cost. Were all of these computer interventions, especially the one in adults, done with handheld computers? Because I noticed that the teen had an iPad, and the question is, was there someone else in the room, or did you have any problems with
them walking away,
disappearing, damage, anything like that?
Yeah, so we do these. We've done. It's a great question. It's a question we're asked a lot. The more tailored interventions. So iPads, as most of you know, the only way to get information onto them is via an app, right? You can't put a program on it otherwise. So we use iPads for screening for some studies that are therapist delivered only. But for these ones that you see, these are a program on a tablet. So those tablet computers, as the iPads are not cheap, and they do have to be monitored in some way. Now, there's a lot of ways to do that. So in our ED in Ann Arbor, where we worry less about theft, we find that we can, an RA or someone can generally kind of monitor that they're in room 2 and in room 4 and kind of float a couple of them around at the same time, and we haven't had any of those walk off. Over the past, I think we've been doing these studies about 10 years now, I think we had one tablet walk off. We more commonly, we have them fall and break and things like that, so we have them in these like bomb-proof, wipeable, cleanable, sanitizable, things that you can put. But there's ways to get around that. I mean, you can put them in our more urban setting. We actually haven't had any of them walk off. We monitor them a little bit more closely, but if that's going to be rolled out better, then they need to be put on a cart, essentially, and locked down. And then you'd have to lean over and do them that way, and then and a cart can't walk away.
I think it's a great idea. There's so much downtime in the emergency department,
right.
And it's a great thing for, I hate to say a filler, but something for
right.
Other patients waiting for something. I can see myself going to my chairman saying that I want all of these handhelds and. seeing
I-
that not going far.
So I don't know if there's anyone here from CHOP or Emory, but at both of those institutions, they've done either kiosks, or at Penn as well, that they've done either kiosks for screening, not as much for the interventions, or have computers in each room, so like desktops, and have the patient go over to it, assuming they're not critically ill, et cetera, et cetera. So there are other solutions, too, besides doing the tablets, depending on what sort of intervention you have. And I know that Rebecca's looking at rolling it out, so
Yeah, so
in a wider
we're trying to
setting.
figure out, especially
Yeah.
the Safe Routine ones, how we can take that and roll it out. And if it's
Yeah.
a therapist assisted, then the therapist has it. You don't have to worry about that. If it's really computer delivered 100%, then you need to make sure that they don't walk off. So, other questions, practical or otherwise?
Safia?
Yeah.
I work at one of the Navajo hospitals in New Mexico, and as part of the federal shutdown, we've been shut down practically, but we do have a very high incidence of teen violence, teen alcoholism, and teen suicide. And I was wondering, and we have one lone SBIRT counselor who's totally overwhelmed, but is very available and very well loved. Is there any way, well, one, are there any materials related to teen suicide? It sounds like you're still in the early stages of developing these, and I know you're reluctant to slap these into different cultures, but in truth, we have little to nothing and little to no money. Is there any way that we could have access to any of these materials?
Yeah, so the suicide, I'm going to set that aside a little bit separately. So to deal with what we had evaluated in this, which is really peer violence and alcohol use. So we have that study's been done. It's been done for 2 years now, and we are working on rolling it out, but we are handing out those materials. So we've been giving out the therapist intervention guide to that study, and I'd be happy to share that with you. We have a CDC-funded study that's looking at trying to translate that into a packageable, disseminable product that when people like you ask me, can I have that, I can say, here, this is the intervention, and this is the training materials your therapist needs to go through to be able to do that. But that's a dissemination implementation project. So we're about a year away from getting that project off on the ground. But in the meantime, I can give you the therapist manual for the one that's focused on teen violence and alcohol.
And does that have anything to do with the computer program that you're showing? With
The computer program that we have here, that's part of the project that we have to translate it. Unfortunately, the computer, one of the things that happens with technology is technology gets outdated pretty quickly. So that technology program that we built in 2004 won't run on anything right now. So one of the, right, there's no program that it will currently run on. So what we have a grant in the next year to take that package that we had before and put it into a platform that we can then disseminate it on, but we don't have that now.
So stay tuned.
Unfortunately.
Okay,
Yeah.
thanks.
We will in a year.
Yeah.
Yeah.
Mike's telephone stuff. It's worth mentioning, kind of the telephone brief interventions can be a telephone and it's an alternative.
I think what Megan is raising is there's other ways to deliver interventions, such as in telephone and telephone brief interventions, which Dr. Mello has done a fair amount of successfully following the ED as another way to save time during the ED.
Thank you, guys. That was great.